Hello, I'm Ailton Fernandes. I'm a urologist focused on reconstructive surgery. I'm here at University Hospitals with Dr. Shubham Gupta and Dr. Mishra. The guys are focused on gender affirming surgery. You're responsible for the team here, and I'm here for a short period, but I've been able to see several surgeries, so the guys have a lot of high volume of surgery. So let's start talk about how the importance to talk about and what does gender affirming surgery mean.
So I can get started. Yeah, I mean, thank you, Dr. Fernandez, for visiting us. Thank you for this opportunity to share some of our insights. I mean, you've been a very, very gracious visitor, and you've definitely sampled a decent amount of Cleveland with going to a lot of different games. So that's great, including a tailgate. I might add. Um, but the idea behind gender affirming surgery is we align a person's physical characteristics to the internal sense of gender identity. And it goes back to the notion that anywhere from 1 out of 200 to 1 out of 100 individuals, at least in the United States, identify as transgender or gender diverse, where their internal sense of gender identity does not align with their external physical characteristics. So, and this misalignment causes distress and dysphoria called gender dysphoria. And the best way to alleviate and eliminate this gender dysphoria so they can be very productive in their social and personal lives is to provide gender affirming treatment, which typically starts with counseling and then will progress over to cross gender hormone therapy. So if someone has male genitalia but identifies as a woman, then we give them androgen blockade as well as estrogens. And then a lot of the time culminates in gender affirming surgery, such as vaginoplasty for trans women. So again, the idea is we are just doing one of the many steps that are part that comprise gender affirming treatment, which is to align the external body to the patient's internal sense of gender identity. So that's gender affirming surgery for you.
Dr. Mishra, we have seen an increased number of candidates looking for this kind of surgery. So, what is the needed requirement to undergo gender affirming surgery?
Yeah, so the requirements for gender affirming surgery are very strict, and we follow a guideline that is actually in place by the WPATH, which is the World Professional Association of Transgender Health. And there's also a US path, and the guidelines align very similarly. But essentially, we want to be doing these surgeries and often life-saving surgeries on individuals that are going to thrive after this. So these might be the strict guidelines ask that the patient has to live in their identified gender role for a year, and that time has been updated now in the most recent guideline. But for the most part, in practice, we use a year as a cutoff. In addition, they also need to be on hormones for a year. And lastly, they need to get letters of support from individuals who feel comfortable evaluating these individuals and can vouch for the fact that they are mentally in a good place, have good social support, and will actually benefit from these surgeries. So, those are the major things that we look for. In addition, as surgeons, specifically, we have guidelines or cutoffs for BMI because we want to be obviously picking the optimal candidates. And it may differ from surgeon to surgeon and from surgery to surgery. In addition, one of the other things that's very important is smoking. So we ask that patients to be completely off nicotine specifically. So no Nicorette gum and patches and things like that. So these are some of the important things that we look for as surgeons for those undergoing surgery.
Dr. Gupta, for people that getting vaginoplasty, what's the main recommendations after surgery?
So, as we alluded to before, vaginoplasty is multiple different operations combined into one. It takes several hours to get that done, and patients typically recover in the hospital anywhere from 5 to 7 days before being discharged. What I tell folks generally is it's a pretty major operation, but most of the patients are pretty young and healthy, so they do have a pretty rapid recovery. But patients are advised to kind of take it easy for at least 4 to 6 weeks. I tell patients that they may be back to about 75% back to normal at about 2 months mark after surgery, and about 85 to 90% back to normal at 3 months mark after surgery. Now, one of the more important things is that the neovaginas that we make are different from natal vaginas in 3 aspects. 1, they don't self-lubricate. 2, they don't self-clean. And 3, these neovaginas tend to stenose or close up on their own. So when these patients go home, it has to be reinforced that they have to adhere to a very strict regimen of dilation, anywhere from 2 to 4 times a day, and a regimen of douching, which is cleaning out their neovagina. Otherwise, they can get a lot of debris and crud built up inside. And whenever they get to the point of being sexually active, since they don't lubricate at a regular rate with sexual arousal, they have to use a lot of external lubrication while being sexually active with any partners. So
You are a robotic surgery, and I see you perform a lot of procedures, especially vaginoplasty. Can you tell us how the robotic can help, especially in patients with complication, maybe for the first procedure, using robotic to assist vaginoplasty?
Yeah, robotic utilization in vaginoplasty is one of the newer methodology that has been used, but people were doing vaginoplasties before the utilization of robot for this. There are a few benefits to it, obviously. Starting off, some of the drawbacks of using the robot, however, are that it's another piece of equipment that is not necessarily available to everyone, especially around the world. It is additional surgery where the bowel is exposed, so there's a higher risk of injury to the surrounding organs. And overall, the canal dissection, if somebody is not familiar with that anatomy, they can really kind of get lost in some of those planes because sometimes those can be a little subtle and may lead to rectal injury. Having said that, the benefits of using the robot are that most urologic surgeons, at least now in the US, are fairly comfortable with using the robots. So that is something where the learning curve we've already passed that point. So more and more people feel like they can utilize the robot, and it's readily available now in most hospitals. The benefit of doing the procedure itself with the robot is that it essentially maximizes the depth that you can give somebody, because you're creating the canal from the proximal most point, which is the reflection of the peritoneum, and dissecting distally, and then you meet with the perineal surgeon halfway through. In addition, it allows you to do a colpopexy. So essentially, you suspend the very top of the vagina in a secure position where it decreases the risk of prolapse. And prolapse is not very common, but it has been reported. And lastly, it also gives you better dexterity and visualization. So the rate of rectal injury prior to utilization of the robot was cited as high as somewhere in one literature as high as 10%. In a meta-analysis, it was said to be somewhere between 1 to 6%. And really, robot has decreased the risk of injury significantly. And in our practice here, we've been fairly fortunate to be able to avoid it altogether.
Dr. Gupta, regarding men trans, what's the options gender affirming surgery for those population.
Yeah, again, kind of restricting ourselves to genital gender affirming surgery. Some of the aspects of components of gender affirming surgery for transmasculine patients. So these had female genitalia and assigned female at birth, but identify as male. So some of the components will include removal of the native female genitalia, so including hysterectomy, oophorectomy, as well as vaginectomy. Okay.
And
but
it comes before the main surgery.
Well, definitely the hysterectomy and the oophorectomy are typically done before, but sometimes they can be combined with. And when it comes to creation of masculine genitalia, there are two options. One is to use the native clitoris, which these patients have been on testosterone for a while, so it's hypertrophied growth size.
True.
So one is to use the native clitoris and use some local flaps and try and make it slightly prominent. And that procedure is called meteorioplasty. But the more common procedure that people do is phalloplasty, which is making a penis. That typically involves taking tissue from another part of the body and then moving it over and then making a phallus out of it. The phalloplasties are typically, so meteorioplasty is one option and phalloplasty is another option. Phalloplasties are typically named after the donor site. So if it's from the forearm, it's called a radial forearm phalloplasty. It's from the thigh, it's called the ALT phalloplasty. It's from the lower abdomen, it's called the abdominal phalloplasty. If it's from this back muscle, latissimus dorsi, then it's called an MLD phalloplasty. So it's really named after the donor site. And different donor sites have different pros and cons and things like that.
Great. Guys, thank you for your time, and I really appreciate this conversation.